Bonjour à tous, bienvenue parmi nous. On va commencer du coup cette session genou qui sera secondairement modérée par le docteur Johan Bohu. On a la chance pour cette session genou d'avoir plusieurs speakers qui nous viennent un peu partout. On va commencer avec Steven Claes qui nous vient de Belgique, qui est un chirurgien du genou là-bas et qui a la particularité d'avoir une énorme expérience sur tout ce qui est pathologie du cycliste, avec vraiment une technopathie bien particulière et qui va nous parler justement de cette expérience qu'il a avec les cyclistes et d'autant plus les cyclistes professionnels.
Merci Alexandre. Alors, bienvenue, bonjour, je suis Steven Claes. J'ai quelques disclosures. La première est que je vais parler en anglais parce que c'est juste un peu plus vite pour moi et plus facile, donc désolé. Just a little bit of the reason why I am here. I'm an orthopedic surgeon, I'm a knee surgeon, and I work in Herentals, which is a little town close to Antwerp, Anvers, in Belgium. I did a thesis, a PhD in 2013 on the anterolateral ligament. I'll discuss some things about that later on in my next presentation. And I'm still doing a lot of research around ACL and osteotomy, and I am a non-professional athlete myself. So what we do in our hospital is we see a lot of sports people, both professional and recreational, and we also have very tight links with a lot of sporting teams and clubs and so on. If you don't know where Herentals is located, this is L'Équipe, you all know, the newspaper. They made a very nice article about my little town a couple of years ago. It was actually called Royaume. Donc we have a royalty in Herentals. And the reason is that we are very centrally located and historically been linked to a lot of things happening in cycling. Like Rick van Looy, an old cyclist who was 2 times world champion, was living in our town, and Wout van Aert and so on, still living there. And I think, to be honest, that our hospital is also very well known for treating these cyclists and can be also in the middle of this royaume à Herentals. Now, I'm not doing this alone. We didn't invent it. Actually, it's a thing which has been going on for years and years and years. And I consider myself really standing on the shoulders of giants. Maybe this is my grandfather, who is deceased now, but he was already the team doctor for the Belgian Olympic team during the Olympics in Montreal. On the right hand, this is my father treating an elite cyclist in the Tour du Qatar some years ago. And nowadays, we're working together even with my brother, who is a shoulder surgeon in our hospital. So this has been a tradition which has been building in the family and in this hospital for decades. So this is just a short intro. We talk about cycling injuries, knee injuries actually, in elite cyclists. And if you're gonna look in the literature, this is one of the publications you will find. This is a publication of 1997. It's a very interesting title. It says Traumatic and Overuse Injuries in Elite Cyclists. This is what we're into. And these are some of the data they provided. The most of the injuries of these cyclists were knee injuries, and these authors called this chondromalacia of the knee. So this is the most common symptom or problem in elite cyclists, according to these authors. It's very common, but the thing is, what we saw so many of these cyclists, and we knew this publication for sure, but we thought, is this really a cartilage overload problem? Does your cyclist really overload the cartilage? Because they only have pain during cycling. If it would be a cartilage problem, they would also have pain going downstairs, or a movie sign and things like that would be positive. But typically, they only feel pain during cycling. And when they stop, all of a sudden, 10 minutes later, they don't feel anything anymore. So we thought this is not very typical for a cartilage problem. Also, you know, chondromalacia, or patellofemoral pain syndrome, as we call it nowadays, is actually treated by cycling. You know that many of our patients, we tell them to cycle in order to get rid of their patellar pain. So cycling is probably not the cause of this, it's more the solution. So we were like, what is actually going on in these elite cyclist knees? according to these authors, chondromalacia, but we were not so sure. Secondly, 10 years later, there was another publication in AGSM, overuse injuries in professional road cyclists, 2010, so the era of Contador and Frank Schleck, Andy Schleck. So they found that, again, overuse knee injuries, anterior knee pain is very, very common. In about 40% of these professional cyclists, they feel anterior knee pain during one season. And it's the most important reason for them not to train or to race. So very important medical problem. So it remains a significant time loss injury, as we call it. Although, again, the paper says injury, overuse injury, but they don't name a diagnosis. Actually, they just name a complaint. It's about anterior knee pain, which is, to me, not a diagnosis. You cannot treat it if you don't know the exact pathophysiology of this term. So the title says injuries, but the article discusses only complaints without being specific. So again, what is the diagnosis in these elite professional athletes, cyclists? And if you think about anterior knee pain, I think you should consider anterior knee anatomy. And of course, you all know that this is the most important structure probably in the front of the knee, which is the patella, la rotule. It has cartilage at the back, and for the rest, some tendons attached to it, and that's it. And still, all these cyclists have pain in this area. And I think you cannot understand the problem of anterior knee pain in cyclists if you don't know this publication. I actually came across this publication by coincidence when I was a lot younger. It's a publication from 2003, black and white kind of photographs. And this deals with the soft tissue anatomy anterior to the human patella, so on the kneecap, on the patella. I still don't know why this guy, Scott Dye, it's an American guy, why he published it. It has no real clinical indications in this publication, but it just studied the anterior anatomy of the patella. And this is something which you should remember. Apparently, there is 3 layers, 3 fascia, running over the patella in the human knee, which is a deep layer, which is the intermediate layer, and which is a superficial layer. And they're actually a continuation of the fascia surrounding your quadriceps muscle. And all these 3, the deepest one actually is the periosteum of the patella, but the 2 others run across it. And it's these 3 layers which we thought were causing the knee pain in these elite cyclists. Because you have to know that whenever a cyclist rides a bike, about 90 revolutions per minute times 4 hours of cycling, just a normal training, this means 20,000 plus revolutions for each knee. If you know that this repetitive cyclic activity can cause pain and your patient comes in straight after cycling with this painful knee in your office, you examine in, you can feel and palpate the patella, and it will be painful. Not the cartilage, but just superficially. Secondly, we have also a test with injection of marcaine or lidocaine, something like that, local anesthetic. When they come in by bike, we inject them and we put them back on the bike and they don't have any pain anymore. So it means that the problem comes from anterior of the patella. And this in combination with the knowledge of this triple layered anatomy of this publication of Scott Dye led to the introduction and the invention, let's say, of our syndrome, which is called the prepatellar friction syndrome. And so we published on that a couple of years ago, the prepatellar friction syndrome. It was quite hard to publish it, because journals typically don't allow you to position a new entity. They want an RCT and so on, but how can you study something when it's not known? So we had a hard time introducing it in literature, but eventually it got published. We did some cadaveric studies ourselves too, and it's quite easy because you have immediately the anatomy in front of you. So with the 3 layers, 1, 2, 3. Now, we had a consecutive case series for these studies, only UCI male elite athletes, Pro Tour, cyclocross and continental tours, young guys with a traumatic or non-traumatic onset of this anterior knee pain. Some of them have a traumatic onset, they crash, they hit the handlebar or the ground, and they have a traumatic disruption of one of these fascia in front of the patella, but most of them have a non-traumatic onset. What is specific to this diagnosis is that they have a very localized tenderness. If you have them come in just after cycling, you can just palpate and feel it, and they go like, ow. Other factors which are interesting is that if you have them pedaling on a higher frequency, they have more pain because they have more friction. If you have them stand up, like en danseuse, riding, it relieves the pain because it's less deeper flexion. And also in winter, this is very typical, and Belgian winters can be very bad, as you know, with a lot of rain and cold, and so they have these long pants and they give an extra layer of compression. So most of these athletes, they come and see me in the winter season at the beginning of the season, exactly the worst timing for these cyclists. And so what you should know about the patellar friction syndrome is that you can see it on ultrasound if you want and compare both knees, but for sure we also do MRI, compare two knees together, MRI, and you will see fluid in between one of these two layers. This is a typical prepatellar friction syndrome. We try and do them conservatively for sure, but in elite cyclists, it's rarely effective. If you are very, very early on, and we train the team doctors to be very looking for this, if they have a crash or an athlete gets pain, they should be very careful, not have them ride too much in the beginning, so take a rest, and then it can probably go away, but in a lot of cases, we need to do surgery. And so in the study we just presented, all patients had to be operated upon with a release of this prepatellar fascia. So this is a typical image. You can see the hole in the fascia there, and this second one is even more clear. So this is how you find it if you dissect it very carefully. And so the operation is actually relatively simple. We have to release these fascia, we have to remove them, and we just close the box. So it's a 10-minute surgery, but it takes a long, long time to recover because we don't have them on the bike for 4 weeks. Otherwise, they will develop a seroma with swelling, which is not good. And secondly, they lose a lot of quadriceps strength. We think that in these fascia, there is the neuroceptive mechanoreceptors, nerve endings and so on, proprioceptive fibers, which will signal a very intense arthrogenic muscle inhibition to the quadriceps straight away after surgery. So they lose a lot of strength, and so to get back to competition, it takes them like 3 months at least. We have some guys who took longer. And so a lot of them have been operated in our service for that. The interesting thing is, it's not only this prepatellar friction syndrome. We've seen so many cyclists, and not everything is a prepatellar friction syndrome. We studied also a consecutive case series of elite cyclists with knee pain, not only anterior knee pain. And what we found is that the big 5 of friction syndromes in elite cyclists are like this. Most of them have prepatellar friction syndrome. So this is half of all the frictional issues in the elite cyclist knees. Some of them have a medial plica syndrome, which is, to be completely honest, I don't think it really exists in other sports than cycling. So I only operate cyclists on a medial plica syndrome. All the rest I don't operate because I think the diagnosis is wrong. But if it's really a friction injury in cyclists, I think it's a very good thing to treat that. Then thirdly, biceps femoris friction syndrome is also not extremely rare. And then other syndromes you might know of, the infrapatellar plica syndrome, I will just explain you shortly, and the ITB friction syndrome. So these are 5 friction syndromes you can also see in cyclists. Remember that. So most important, PPFS, prepatellar friction syndrome, but secondly, the infrapatellar friction syndrome. I think it's a really interesting syndrome. All of these athletes had these kind of procedures, as you can imagine. But the infrapatellar friction syndrome is caused by the ligamentum mucosum. It's actually a connection from the patella towards the femur, running in front of the Hoffa fat pad. It's quite rare. It's hard to diagnose because they complain of deep central knee pain during cycling. And it's very hard to diagnose this. In some cases, you can see this on MRI. And if you see it on MRI, this is a typical case. You see the extension of Hoffa fat pad running towards the femur. surgeons know it very well because in arthroscopic surgery, we go into the knee and all of a sudden it's there in the middle of our view. So we always take that out when we see it. But in some cases, it can cause pain in cyclists. And this has not been described before either. So you have to do the MRI, but a lot of people have this IPP without any without any complaints. So you really need to make sure this is causing the injury. Again, diagnostic injections and so on can help. But if you see it like this, again, you see how it rubs on the trochlear groove. If this is an elite cyclist and this was one, it can cause pain because it pulls on the hoffa and it can give some irritation. Easy surgery, just release, take it out, and they're happy as long as the diagnosis is correct. Medial plica syndrome, I told you, I'm not a big fan of this diagnosis in normal people like you and me, but in cyclists, it's very frequent a cause of medial-sided knee pain. You know what the plica is, it's an embryonic rest, and it becomes some kind of fibrotic band, becomes painful and swollen, and again, you can do the same local anesthetic injection test after cycling if you want to be sure. It's really very helpful to do this kind of tests in cyclists to find out where the friction comes from. And what's also interesting in cyclists is that everything you know about knees for the rest, you can completely forget because cycling doesn't need meniscus, no ligament, no nothing. It's a completely different sport. So everything you know and think about, forget about it. This is only about friction. And so medial plica can be treated conservatively, quite good, better than prepatellar friction syndrome. But if it's very resistant to conservative therapy, we also operate it arthroscopically, and then we just remove a plica like this one. So that's also rubbing. And then finally, the two, let's say, less important ones maybe, biceps femoris friction syndrome. It's actually the biceps tendon who rubs at the fibular head. And in all cases, we found that clinically and also during surgery, there is some kind of prominence on the fibular head which rubs against the biceps tendon. Some kind of like a prominent exostosis on the bone. It can also cause a real snap. I had one cyclist who had a real audible clack, clack every time he rode a bike. This is very well treated by adapting the position of the cleat, so of the foot, the shoe, on the pedal. If you give some more external rotation of the foot, the biceps tendon gets relaxed during cycling, so you can change the biceps tendon problems very well with positioning on the bike. So that's what I wrote. Bike positioning adaptation is very helpful in biceps tendon friction problems. In some cases we need to operate, but it's quite rare. And for sure, the treatment is involving as well removal of the bony prominence, which causes the rubbing of the tendon. And then finally, ITB friction syndrome, you know that very well. We see it a lot in runners, but also in cyclists. So it's not very rare to have it in cyclists. And I operated 3 elite cyclists last year just because they start running in the off-season. So don't have your cyclists run. If they're not used to that, they will get an ITB pretty soon. So I think it's a mistake to have your professional cyclist, run in the off-season because it increases the risk for a very hard-to-treat ITB friction syndrome. So the diagnosis is completely the same as in your runners. There is some weaknesses involved and also leg length discrepancy, but in cyclists, again, saddle and cleat position can adapt it slightly, a little bit the same like with the biceps femoris, because it's a laterally sided frictional structure. So that's about it. These are the friction syndromes in cycling. I think you just should remember that not all anterior knee pain is chondromalacia. Actually, I think it's never chondromalacia. It's never just cartilage, and actually it's also never meniscus and so on and so on. It's always a frictional syndrome, and most of them can be related to one of the 5 friction syndromes I just explained to you. And so really think about friction if you deal with elite cyclists, please. Thank you. I'm not sure if we do questions now or later. Are there any? Okay, thank you.